So Premeds, I think, what are the side effects up front? And we're trying to mitigate many of them going forward with infusions that patients will get. Usually in the first dose, they'll have everything pretty much IV, intravenously. Corticosteroids will give them acetaminophen, and IV oral antihistamines up front. At our institution, we did use Singulair in our pre-meds to help prevent the cytokine release and the shortness of breath or bronchospasms, but we also use Pepcid, like an H2 inhibitor, that can be done. But in the clinical trials, they only really use the corticosteroid, the Tylenol, and the antihistamine. IV is appropriate for upfront, but if the patient truly tolerates the medication, then it can all go to oral. Generally, it's given 1 hour prior to the starting of the daratumumab. I know in many institutions, in the community, if they're taking oral, the option is 1 to 3 hours, so patients can actually take the medications at home and then go to their infusion center and then receive the daratumumab. But I think that's something you have to know if the patient truly is oral adherent and they're really going to take those drugs up front.
Yeah, I think it's great. The pre-meds are super important. Maybe you could comment on a lot of myeloma regimens obviously contain DEX already. So you have these kind of steroid pre-meds that are part of the DARA label, but then you're also asking patients to get DEX. How do you manage that?
So it is interesting that, yes, steroids is the backbone of really what myeloma does. We will pre-med them. Usually in the clinical trials, they did use methylprednisone. It was 100 milligrams for the first dose, and it dropped down to 60 milligrams. I think when patients are on long-term daratumumab, and if they're in complete remission, we at our institution are starting to pull the steroid actually out of the regimen if there's no need for it, because a lot of times our patients are much more mature in age and they have other comorbidities. So you're dealing with hyperglycemia or other issues going on. So you can remove the steroids up front. They use methylprednisone up front, but they also use dexamethasone because it was the backbone of the other medications, whether it was bortezomib or lenalidomide. So dexamethasone was substituted for it. Again, that's also an option to switch from methylprednisone to it. An interesting thing to keep, whether it's pre-meds, after their infusion, it was recommended to give steroids post daratumumab because there was seen some delayed hypersensitivity up to 48 hours. So patients were giving methylprednisone for 2 days or dexamethasone the day after of it. And again, if in our institution, to be truly honest, if the patient truly does not have any side effects from it, we've removed the post-DARA dexamethasone, again, decreasing their exposure to it.
Yeah, I agree. I think the only caveat I would add would be that if somebody has a significant respiratory history, be it asthma or COPD, since a lot of those patients may not have always been included in clinical trials, that's probably the one subgroup of patients where, at least for the first dose, it may not be a bad idea to do the post-dose. But I think to be giving it for everyone, for the most part, we don't really see a lot of delayed reactions, and I think it's probably not needed.